thank you very much. You bring us with very important data that for the patient's sake, many of the patients have a HER2 positivity may benefit, but from pharmaceutical and clinical side of view, there will be more use of drugs and more dual blockage of HER2, and this may bring us some problem in the future, but thank you very much. Now we have a star from Johns Hopkins Cancer University. She is Professor Leisha Emens. She is a professor of oncology, Cancer Center, Johns Hopkins University. And she will also give us a very basic and important information that may change our practice, talking about microenvironment. Her title or her presentation title is Breast Cancer Microenvironment, a Potential Target for the Therapy. And if you allow me, this was a very important presentation in the last San Galen in the introductory session, and it was very, very important. So please, Dr. Leisha.
All right, good afternoon, everybody. I'd like to thank Dr. Hesham El-Ghazali and his organizing committee for the very kind and generous invitation to return to Cairo. I really enjoyed the meeting last year, and it's a pleasure to be back, and also for the very generous hospitality. So I'd like to go over where we are with targeting the breast tumor microenvironment, and really that's, to a large degree, all about breast cancer immunotherapy. These are my disclosures. This is a slide that just summarizes the interactions of breast cancer and the immune system. And unlike some other tumor types, such as melanoma and lung cancer, breast cancer tends to be a colder tumor. There are some differences across the subtypes, and if you look here on the left-hand part of the slide, you can see two stains for CD3 positive T cells. In the left panel, you can see a cold tumor where you really don't see any staining at all. And in the right panel, you can see a hot tumor where you see some brown staining sprinkled throughout the tumor microenvironment. So these reflect T cells actually getting into the tumor, whereas on the left side, there's really no T cells that are present. In order for immune checkpoint blockade to work, particularly the PD-1, PD-L1 agents, you need T cells present within the tumor because they are what is unleashed by the therapy. If you look across the breast cancer subtypes, underneath those, I've tried to illustrate the spectrum of T cell infiltration across the breast cancer subtypes. Triple negative breast cancers tend to be the most likely to be infiltrated by T cells and other immune cells. HER2 positive breast cancers are also highly likely to be infiltrated by immune cells. In contrast, ER positive breast cancers or luminal breast cancers are unlikely to be infiltrated. However, rare ER positive breast cancers are infiltrated. It's very clear now that poor prognostic factors, tumors that are ER negative, PR negative, of high grade, and lymph node positive, also tend to have higher T cell infiltrates at diagnosis, higher numbers of CD8 positive tumor infiltrating lymphocytes, as well as a higher ratio of good T cells, the CD8 positive T cells, to the bad T cells, those FOXP3 positive Tregs. The higher that ratio, the more likely a patient is to have a better clinical outcome with regard to complete pathologic response rate, disease-free survival, and overall survival. This is true of triple negative and HER2 positive breast cancers, but not necessarily for luminal cancers to date. Both triple negative and HER2 positive breast cancers appear to be high-value targets for cancer immunotherapy. In particularly, triple negative breast cancer is an attractive candidate for this because it has no approved targeted therapies until recently, with olaparib for BRCA mutated triple negative breast cancers. And there are, for HER2 positive breast cancer, some potentially synergistic targeted therapies. ER positive breast cancers present the challenge of transforming tumors from cold to hot. So this is the largest reported data set for the activity of an agent that targets the PD-1 axis. And this is the monoclonal antibody avelumab, which is specific for PD-L1. And this is across breast cancer subtypes. On the left, you can see the spider plot, which reflects the activity of this agent in 168 PD-L1 unselected patients of all breast cancer subtypes. The response rate is pretty low. It's about 4.8%, and this is in contrast to other solid tumors where the response rates tend to be more on the average of maybe 15 to 30%, depending on the tumor type. In this particular group of patients, there was 1 patient with a complete response, there were 7 partial responses, and 39 patients with stable disease for an overall disease control rate of 28%. And on the right side, you can see the waterfall plot reflecting this data. Moving on to the PD-1 agent pembrolizumab, this reflects the activity in triple-negative breast cancer as initially reported by Rita Nanda, and ER-positive breast cancer as initially reported by Hope Rugo, who spoke to us earlier. These are breast cancer patients who were pre-selected for PD-L1 expression, so that's a very important thing to keep in mind. If you look on the left side, this is patients with triple-negative breast cancer who were pre-screened, and 58% of 111 patients turned out to have PD-L1 positive tumors and could potentially enroll on the study. There were 27 patients treated on this study with a response rate of almost 19% and a progression-free survival rate of 23%. Again, a complete response, 4 partial responses, 7 patients with stable disease. And these responses tend to be durable with this class of agents, similar to other tumor types. On the other hand, on the right side, you can see that the ER-positive breast cancers were much less likely to be PD-L1 positive, and almost 250 tumors had to be pre-screened to identify the number of patients that were potentially eligible for this study. So about 20% of the pre-screened tumors were PD-L1 positive. This is because those ER-positive breast cancers tend to be cold. The overall response rate here was 12% with a progression-free survival rate at 24 weeks of 20%. This is in 20 patients, so a very small data set. There were no complete responses in this tumor type and 3 partial responses, and there was evidence of pseudoprogression seen in this particular data set. This summarizes the data to date for all of the agents. If you look at avelumab, for 168 patients overall, the response rate's almost 5%. If you drill down into those patients across subtypes who are PD-L1 positive, the response rate in this group goes up to 33%, but only 12 patients accounted for that. If you look specifically at triple-negative breast cancer patients, there were 58 of those in this study and almost 9% response rate. Of those triple-negative breast cancers that were PD-L1 positive, the response rate was much higher, about 44%. Again, a very small number of patients, only 9 patients. If you look at pembro, the response rate, as I showed you, was about 18% for PD-L1 positive triple-negative breast and 12% for PD-L1 positive ER-positive breast. And for atezolizumab, I'm going to show you the most recent data reported for that. So this shows the entire cohort for the patients treated on the phase 1A trial. This was a patient population that was enriched for PD-L1 expressing patients, but also ultimately included some PD-L1 negative patients. The age of these patients was 53. They tended to have a performance status of 0 or 1 because that was required for eligibility. They were pretty sick patients, so 65% had visceral metastatic disease, 30% had bony metastatic disease, 63% were PD-L1 positive, whereas 33% were PD-L1 negative by this particular assay. Again, this does not reflect the prevalence in the general population because initially this trial restricted enrollment to PD-L1 positive patients. So this does not mean that 63% of triple-negative breast cancer patients are PD-L1 positive. Very heavily pretreated patient population with a median number of systemic therapies of 7, with a range all the way up to 21. Importantly, there were some patients treated first line on this study as well. This shows you what types of therapies they'd had before. There were 115 patients eligible for toxicity and 112 eligible for objective response. The median treatment duration overall was about 2.1 months with a median of 4 cycles. So this shows you the spider plot for this group of patients. As you can see here, the curves in red reflect patients who had progressive disease. If you take those away so that you can actually see the clinical benefit by RECIST and immune-related RECIST, because we also saw pseudoprogression on this trial, the median duration of response was 21.1 months, with a median progression-free survival of 1.4 months by RECIST and 1.9 months by immune-related RECIST. Again, the responses are very durable when they occur. This looks at the response rates by subgroup. If you look at the patient population overall, in 112 patients, the response rate was 10% by standard RECIST, up to 13% by immune-related RECIST. Responses were numerically higher in patients who were PD-L1 positive at 13% and 17%, and they were also higher in patients treated first line at 26% versus second line or greater at 4 to 11% or 8 to 11%. Again, this is a finding that's being played out across multiple data sets with multiple drugs. So it appears that PD-L1 expression enriches for the likelihood of response, and treating patients first line is likely to be more effective than later line or greater. Importantly, the response tends to correlate with an overall survival benefit. In this group of patients, the overall survival was 9.3 months in all patients, with landmark overall survival rates of 41% at 1 year and 22% at both 2 and 3 years at the first analysis. You can see that people who had either a complete or partial response had 100% of survival. So for those patients, this therapy is quite transformative. Even patients who had stable disease had a survival benefit by both RECIST criteria compared to patients with partial disease. If you look at the RECIST curve, you can see there's actually even a tail of the curve here with an overall survival benefit in patients with progressive disease at 11%. This reflects pseudoprogression because if you take into the account over here, you can see that that tail of the curve does not appear in the patients with progressive disease. If you look at overall survival by PD-L1 status, you can see that overall survival is observed. Longer overall survival is observed in patients with a higher PD-L1 status by IHC, with a 1-year survival of 45% versus 37% for PD-L1 negative patients, and there's a tail of the curve here as well with a 2 and 3 year overall survival rate of 28%. The median overall survival overall, again, was 9.3 months. This increased slightly to 10.7 months for patients that were PD-L1 positive, whereas it was 7.1 months for patients who were PD-L1 negative. This looks at the association of response and survival with TILs by H&E, and this was stratified at the median, which was about 10%. And you can see that both the response rates and survival correlated with higher TIL levels. And in particular, if you look at the survival benefit in patients with low TILs, less than 10%, the median survival was 6.6 months, whereas those who had higher levels of TILs, the survival was 12.6 months. So pretty impressive correlation. And the same holds true for CD8 positive T cell infiltrates as well. This is data from the phase 2 Keynote study, Keynote 86, which is the phase 2 study of single-agent pembrolizumab and metastatic triple-negative breast cancer. 2 cohorts on this study. Cohort A enrolled previously treated PD-L1 unselected patients, and there were 170 patients reported at ASCO and updated at San Antonio. The response rate here is 4.7%. If you look at PD-L1 expressing patients, it was also about the same level at 4.8%. And PD-L1 negative patients were about the same. So PD-L1 expression didn't appear to correlate with response in this particular group of patients. There was a slightly higher disease control rate of 9.5% for patients who had PD-L1 expression versus 4.6% for patients that did not. Again, these were patients who were not treated first line. They were previously treated and had at least one prior line of therapy. There was initial data reported on 52 patients who were PD-L1 selected and treated first line, and the overall response rate increased to 23%, very consistent with the atezolizumab data that I just showed you. So that's kind of where we are with things in triple-negative breast cancer. I didn't include the Panacea data in the interest of time, and I'm going to move on to some challenges for the field. So really there's 3. The first is deepening responses to single-agent immunotherapy with combinations. The second is converting patients who don't respond at all into responders. And the third is personalizing immunotherapy. So really it's all about combinations. There's a plethora of trials on clinicaltrials.gov now, and this is a figure taken from a review that I wrote and published in Clinical Cancer Research, and looks at different types of combinations with PD-1 or PD-L1 antagonist as a backbone. And I'm going to touch a little bit on chemotherapy, unique type of vaccine that targets the STING pathway, and other immune checkpoint modulators later in the talk. So one framework for personalizing breast cancer immunotherapy is looking at whether a tumor is cold or hot, or non-inflamed or inflamed. And I'm going to focus on the cold tumors because that's really our biggest challenge. These are tumors that don't have T cells. And one thing that people are trying to do to increase the response in this group of patients is combining PD-1, PD-L1 antagonists with standard chemotherapies. There have been 2 studies reported. The first is atezolizumab with nab-paclitaxel. You can see that the response rate here is 41.7%. If you look first line, the response rate was higher at 67%. This is shown in the left panel. Whereas patients who were treated second line or greater, the response rate was 25 to 28%. Again, this concept that earlier in the course of therapy is better for immunotherapy. Data has also been reported for the combination of pembrolizumab with eribulin, and the response rate reported at San Antonio originally was 33%. The updated response rate is more on the order of 25%, so that did decrease a little bit. Interestingly, these chemotherapeutics have some immune modulatory activity where the taxanes can induce antigen release, signal through the toll-like receptor, and activate innate immunity, and by virtue of doing that, augment the activity of dendritic cells and antigen presentation. Eribulin also has immune modulatory activity by releasing antigens and priming the T cell response. It can also decrease Tregs and suppressive M2 macrophages. So the atezolizumab data forms the basis for this randomized global phase 3 trial, which enrolled 900 patients to receive atezo with nab-paclitaxel or placebo with nab-paclitaxel. It has co-primary endpoints of progression-free survival and overall survival. It's completely accrued, and we should be hearing data about that soon. This is a slide that just illustrates that there's more complexity to the tumor microenvironment than we tend to appreciate, and the heterogeneity of the architecture probably matters. This was data presented at San Antonio by Grasso and colleagues, and looks at a completely cold tumor, as shown on the far left, a tumor that's margin restricted or immune excluded tumor, where the T cells are trying to get into the tumor, but they're restricted to the very edge, and there's just this circumferential collection of T cells around the tumor. Next, you have stroma-restricted T cells, where the T cells are getting into the tumor, but they're not getting into the tumor nests. They're in the stroma, but not adjacent to the tumor cells. And then fully inflamed on the far right, you can see those T cells coursing throughout. There's different features associated with this, where the cold tumors are highly fibrotic, and the fully inflamed tumors have a T helper type 1 signature and high activity of granzyme B as well as PD-L1. So just to go on to a vaccine type approach, this just illustrates again a model where you have a cold and a hot tumor. We have evaluated a novel intratumoral vaccine that targets the STING pathway that you heard about from Joyce O'Shaughnessy earlier this morning. These are tumors that have when they're inflamed, they have an interferon beta transcriptional signature. It turns out that STING is the critical receptor to activate immune cells, including dendritic cells. And you heard earlier that tumor-derived DNA induces interferon beta by tumor-resident DCs through this STING signaling pathway. And the idea is that if you can inject a drug into the tumor that activates the STING pathway, you can transform a tumor from cold to hot and really poise it to respond to immune checkpoint blockade. And this is data that we evaluated in a non-tolerant mouse, the FEBN mouse, where these mice mount a fabulous response to immunotherapies, versus a tolerant mouse that is tolerant to HER2, where the mice cannot mount an immune response at all. We queried the proximal part of this pathway, which is interferon beta secretion, and you can see that relative to buffer control, injection of the STING agonist induced good interferon beta, both in the non-tolerant as well as the tolerant mice. If you look at biomarkers of antigen processing and presentation, there was no difference between the tolerant and non-tolerant mice with regard to those biomarkers. However, if you look at T cell activation and proliferation, you can see that in the non-tolerant mice, you got good activation as well as good proliferation, whereas you didn't in the non-tolerant mice. And that difference also held up if you looked at T cell migration as well as T cell function, where you had good T cell function in the non-tolerant mice and absolutely none in the tolerant mice. We took a look at the immune checkpoints expressed on immune cells in the non-tolerant and tolerant mice and found that both OX40 as well as PD-L1 were upregulated in the tumor microenvironment relative to the spleen. So we combined this intratumoral sting vaccine along with PD-L1 blockade and OX40 agonists, and you can see the tumor curves here, whereas untreated tumors grow out. If you add all three agents together, you get a pretty nice delay in tumor growth and actually can cure about 40% of these mice of their tumors. So this looks like one promising approach to transform tumors from cold to hot. If you look at the T cells that are present here, you can see that you get by far the greatest numbers with all three agents combined versus any of them alone. And if you look at function, you can see that you get the best function here with all three agents combined as well. So in conclusion, what I've tried to demonstrate for you is that breast cancer can be immunogenic. Most breast tumors are not. There are differences across the subtypes. There are multiple layers of regulation within the tumor microenvironment that can shut down tumor immunity, including Tregs, macrophages, other immune checkpoints, vaccines, standard vaccines, as well as novel vaccines like the sting agonist could potentially prime the tumor microenvironment by recruiting T cells there in order to respond to immune checkpoint blockade. There are standard cancer therapies that can augment the activity of immunotherapies. Really, the futures and combinations that should have synergistic clinical activity but may come at a toxicity cost, and we really need to do smart trials that can elucidate immune mechanisms of response and resistance in patients. My time is up. These are my acknowledgments, and I'd really like to thank, in particular, all the patients and their families who participate in these trials, because it's got to be a scary thing, receiving experimental therapies when you have a really bad disease. Thank you very much.